Welcome to your first day of Synergy Classroom training. By now, you should have successfully completed the online independent study portion of your training. In this next phase, you will learn to incorporate the material you just learned into your workflow as a medical concierge in the emergency department. Synergy Medical Concierge Services is dedicated to providing premium concierge services that support the delivery of high quality, efficient, and compassionate care in a collaborative environment. Here at Synergy, we promote a culture of positivity. We believe that having positive interpersonal relationships in the workplace encourages learning and workplace involvement. We pride ourselves on being a collaborative, non punitive team that strives to deliver high quality work in all of our endeavors. In the emergency department, how we do what we do is just as important as what we do. We invite you to work with us to continually establish a culture of compassion, teamwork, collegiality, and professionalism. With that, we hold our medical concierges to the same professional standards as our emergency physicians and the rest of our department staff. Medical concierges play a dual role in the emergency department. They provide concierge services for the provider and concierge services for the patient. Your experience as an MC will benefit you immensely. You will have an invaluable learning and professional experience. You will have the opportunity to be a part of a team that provides compassionate care to patients, and you will gain assistance in your pursuit of long-term career goals. It is important to keep in mind that a medical concierge is not a medical scribe. We have a much more involved role in the department and patient care team. While you will become very involved in patient care, there are a few things you must keep in mind. Concierges may not examine patients, they may not provide medical information to patients, they can't act as a translator, make independent decisions, or document without physician oversight. So, who works in the emergency department? The ED is home to many personalities. The clinical staff is composed of emergency physicians, this includes attendings and residents, and advanced practice providers. This includes nurse practitioners and physician assistants. There's also ancillary staff that's composed of clinical nurse managers, nurses, medical assistants or techs, transport, radiology techs, and unit clerks. The emergency department is a dynamic place. There's always variability of age, gender, race, culture, and disease severity. Even so, patients progress through flow through the emergency department in several ways. Arrival, triage, here the severity of their current complaint is determined according to an emergency severity index. Room assignment, then nursing assessment, physician assessment, and disposition. This is where their next step after their ED visit is determined. They may be admitted to the hospital or discharged back home. In this workflow, the emergency provider has 4 primary responsibilities: stabilization and resuscitation, diagnosis, treatment, and disposition of patients. Now, we are going to briefly review HIPAA and walk through a few scenarios you might encounter while working. What is HIPAA? From your training, you may remember that HIPAA stands for the Health Insurance Portability and Accountability Act. It is a federal law that requires Synergy to protect the privacy of patient information, secure the protected health information both physically and electronically, adhere to the minimum necessary standard for use and disclosure of patient healthcare information, and specify a patient's rights for access, use, and disclosure of their health information. To clarify further, protected health information is information related to a patient's past, present, or future physical and/or mental health condition. This includes information in any format, whether it is written, spoken, or electronic. Except for treatment, the minimum necessary standard applies. For patient care and treatment, HIPAA does not impose restrictions on use and disclosure of PHI or protected health information by healthcare providers. Exceptions include psychotherapy information, HIV test results, and substance abuse information. For other purposes, HIPAA requires users to access the minimum amount of information necessary to perform their duties. So, example, a billing clerk may need to know what a laboratory test was done, but not the result. Patients may see normal clinical operations as violating their privacy. Therefore, it is important to be aware of your surroundings when talking. Ask yourself, what if my information was being discussed like this? If you are not sure when it is appropriate to view, use, or share PHI, it is only appropriate when required for your job. Here's one scenario you may encounter in the emergency department. I do not work with patients or have access to medical records. However, I see patients pass by my desk in the clinic. Can I talk about the patients with my coworkers, family, and friends, even if it has nothing to do with my job? A. You may not discuss any patient information with anyone unless required for your job. B. You may only talk about the patient with your coworkers. Or C. You may only talk about the patient with your family and friends. The answer is A. You may not discuss any patient information with anyone unless required for your job. Again, information can only be used as needed for your job. Scenario 2. My coworker's boyfriend notified me that my coworker was recently admitted to the emergency department and won't be coming into work tomorrow. My coworker and I have a great relationship and I'd like to know how she is doing. May I access her records to check on her condition? A. It is okay as we are friends, so I'm sure she wouldn't mind me looking at her records. B. I already have approval to access patient clinical systems, so no one will know that I accessed it. Or C. It is not necessary for my job, so I would be violating the patient's privacy by accessing her records. I should contact her husband to check on her condition. The answer is C. It is not necessary for my job, so I would be violating the patient's privacy by accessing her records. I should contact her husband to check on her condition. It is not part of your job. Your access to your coworker's record would be for personal reasons. Therefore, accessing the record will be a violation of your coworker's privacy. Scenario 3. You are very upset because a young patient of yours has just coded and was not able to be resuscitated. You want to share this experience and your thoughts and feelings with your family and friends on Facebook. What must you consider before doing this? A. Posting this on Facebook is okay as long as you do not identify the patient by name or identify the hospital and you are limiting the recipients to your friends and family. Or B. You cannot post anything on Facebook that could possibly lead to identification of the patient. The answer is B. Facebook is considered public domain and anything you post there is considered public information. Posting clinical details without prior authorization is a violation of your patient's privacy and confidentiality. Your Facebook profile may identify your place of work and your occupation. When linked with your posting and any other publicly available information, the additional details may identify the patient. Information you obtain from your patient-provider relationship is confidential. Now finally, scenario 4. A man arrives at the emergency department by himself and asks you to call his wife. You leave a voicemail for the patient's wife, stating her husband John is in the emergency department complaining of chest pain. Was this a privacy breach? A. No, the patient gave you permission to call his emergency contact. B. Potentially, you identified the patient and why he is in the emergency room. Or C. No, I did my best to keep his identifiers to the minimum necessary. The answer is B. Potentially, you identified the patient and why he is in the emergency room. Patient name in conjunction with medical information constitutes PHI. You do not know who will hear the message. The patient may want to withhold his visit to the ER from his children or other family members. It is best practice to leave the minimum amount of information needed, your name, phone number, and that you're calling from St. John's Riverside Hospital. Never leave PHI on an answering machine. Now, we are going to begin discussing basics of documentation. To begin, we will discuss the purpose and the elements of the patient's chart. The patient's medical chart has 3 main functions: to document the story in emergency department course for other healthcare providers, to substantiate billing. Our medical charts are sent to an external billing company who uses items in the chart to code for medical reimbursements from insurance companies and to serve as a legal record. There are several sections of the chart, including the history of present illness, or HPI, physical exam, or PE, review of systems, or ROS, medical decision making, or MDM, and the disposition. So first we'll talk about the history of present illness. The HPI, or history of present illness, is a subjective account of the patient's current medical condition and the events that lead up to it. It describes the chronology and quality of the patient's symptoms. So what belongs in the HPI section? You have simple patient characteristics, so their age and gender, their pertinent past medical history, and for female patients, you can include things like postmenopausal states, pregnancy calculations, menstrual cycles, etc. It includes the chief complaint, and it includes elements that describe the chief complaint. It includes pertinent positive and negatives from the review of systems and pertinent pre-hospital events. So, for example, did they arrive via EMS from a nursing home? And primary care provider information, which is necessary for patient referral and admission. So in the previous slide, we mentioned elements. The HPI should include the following basic elements whenever possible. And elements of an HPI can include these things describing the patient's symptoms. So onset, severity, quality, location, timing and duration, context, modifying factors, and associated symptoms. To elaborate, the onset is when did the patient's symptom or symptoms start? Severity, how bad was the pain? Pain scale 1 to 10, or descriptive words like mild, moderate, or severe work for severity. The quality, was the pain sharp, dull? Was it a burning sensation or tingling? These are descriptive qualities or adjectives describing the pain. You can describe the location as an element. Where is the pain located? Does it travel or radiate to another location? You can use anatomical positions to really focus this down. The timing and the duration. Is the pain constant, intermittent? Does it get progressively worse? Did it resolve prior to the patient's arrival? Or are they unsure of when the pain really began? Context. What brought the patient to the emergency department today? Modifying factors. Is there anything that makes it worse or better, like movement or eating or rest? And associated symptoms. What are other symptoms that the patient has admitted to having as the story develops? This will move into the pertinent positives and negatives from the review of systems. So here's an example of an HPI. A 68-year-old female with history of end-stage renal disease on dialysis Monday, Wednesday, Friday, hypertension, diabetes, CHF, presents with shortness of breath and chest pain. The patient had a recent hospitalization for nausea and single pole episodes that she is currently undergoing workup for. She states that the last several days she is having intermittent chest pressure and shortness of breath. The patient notes that the symptoms are worse and worse with exertion. She denies any fever, chills, cough, abdominal pain, diarrhea, or leg swelling. The patient did note she had a syncopal episode approximately 1 week ago after dialysis. She did not follow up with her doctor, but she noted that she was hospitalized twice already for this complaint. The patient called her doctor, and the covering doctor told her to come into the emergency department for evaluation. The patient is currently asymptomatic. So what parts of an HPI that we just discussed can you notice here? First, we can look at the first sentence. This gives a brief snapshot of who the patient is and why they're in the emergency department today. It complains the chief complaints of shortness of breath and chest pain. Then there are elements that describe the chief complaint. If you read through it, it describes the chief complaint as intermittent, worse with exertion, and it also describes the timing and context. She had a syncopal episode 1 week ago after dialysis. There are pertinent negatives. These are the symptoms that the patient does not have. So she doesn't have fever, chills, cough, abdominal pain, diarrhea, or leg swelling. These elements that we just described are important in telling the story of the patient's complaints. When you're documenting, it is important to be clear in where you are getting your information. Sometimes your information will come from sources other than the patient themselves. You must always explicitly inform the reader where your information is coming from. Possible history sources include the patient, care provider, parent, significant other, EMS, nursing home records or old records, and some possible exam limitations include no limitations, this is what is most common, clinical condition, intubation, dementia, intoxication, or a language barrier. You can indicate the history sources in Meditech, our electronic health record. When you open up the patient's chart for editing, you click the appropriate button for history source and exam limitations at the top of the form. You should still indicate this in your writing as well. Now we will discuss how to craft the HPI. The HPI explains why the patient is in the emergency department today. It can be crafted using a 5-step process. Number 1, identify the chief complaint. 2, craft your first sentence. 3, describe the elements of the chief complaint. 4. List pertinent positives and negatives. And 5. Describe pertinent pre-hospital events. So, step 1, identify the chief complaint. This is what brought the patient to the emergency department today. What is the patient describing in most detail? In this video, try to identify the chief complaint.
Hi, I'm Dr. Saxena. How can I help you today?
Hey, I'm Tom. I'm having chest pain.
Oh, Tom. Sorry to hear that. We'll take good care of you. How long has this chest pain been going on?
It started like.
So I'm going to stop it right there. In this scenario, the chief complaint is chest pain. Sometimes it is as simple as that. In other patient interviews, the chief complaint is less clear. Step 2. Once you've identified the chief complaint, you craft the first sentence. This is a snapshot of the patient today. It includes the patient's age, gender, pertinent past medical history, the chief complaint, which we just identified, and the basic timing of the patient's complaints. Here's another example. The patient is a 42-year-old female with significant past medical history of asthma and current cigarette smoking who presents with 2 days of cough and fever. The first sentence should be as concise as possible. You can add in details with the rest of the paragraph. Now, practice building your first sentence using the same scenario. You've been giving his demographic information on screen.
Hi, I'm Dr. Saxena. How can I help you today?
Hey, I'm Tom. I'm having chest pain.
Oh, Tom. Sorry to hear that. We'll take good care of you. How long has this chest pain been going on?
It started like 3 hours ago.
Okay, and where is it exactly?
It's right over here. It's over here.
Okay. Does it go anywhere else, or does it stay there?
It goes to like my shoulder over here.
Okay, and what does it feel like?
It feels like this someone's like standing on my chest right here.
Okay. Scale of 1 to 10.
10.
To 10. Okay, is it there all the time, or does it come and go?
It's there all the time.
Has this ever happened before?
Yeah, it happened before. I had a heart attack before.
Okay. When did you have your heart attack?
About 4 years ago.
Okay.
And then they did the thing where like they go like they put a little cut in your leg and they like opened up my arteries.
Oh, called a stent? Does that sound familiar?
Yeah, I think so.
Okay. A couple more questions about your chest pain. Anything that makes it worse?
Yeah, like when I'm like was walking in, it was definitely a lot worse.
Okay.
Your first sentence should sound like this. The patient is a 48-year-old male with significant past medical history of heart attack, or you can say myocardial infarction, which is status post stent, who presents to the emergency department complaining of about 3 hours of chest pain. Again, the first sentence should be concise. Leave out the modifiers for the rest of the HPI. Now you try to identify modifiers describing the chief complaint of chest pain. Again, this includes modifiers like onset, severity, quality, location, timing and duration, context, and modifying factors. We are going to practice again with the same clip.
Hi, I'm Dr. Saxena. How can I help you today?
Hey, I'm Tom. I'm having chest pain.
Oh, Tom. Sorry to hear that. We'll take good care of you. How long has this chest pain been going on?
It started like 3 hours ago.
Okay, and where is it exactly?
It's right over here. It's over here.
Okay. Does it go anywhere else, or does it stay there?
It goes to like my shoulder over here.
Okay, and what does it feel like?
It feels like this someone's like standing on my chest right here.
Okay. Scale of 1 to 10.
10.
To 10. Okay, is it there all the time, or does it come and go?
It's there all the time.
Has this ever happened before?
Yeah, it happened before. I had a heart attack before.
Okay. When did you have your heart attack?
About 4 years ago.
Okay.
And then they did the thing where like they go like they put a little cut in your leg and they like opened up my arteries.
Oh, called a stent? Does that sound familiar?
Yeah, I think so.
Okay. A couple more questions about your chest pain. Anything that makes it worse?
Yeah, like when I'm like was walking in, it was definitely a lot worse.
So you should have noticed the following modifiers. The chest pain was left-sided, it radiates to the left shoulder, it's pressure like squeezing pain, it's ranked 10 out of 10, and it's worse with walking. Continuing in how to craft the HPI, step 4 is including the associated symptoms. You should include both pertinent positives, or symptoms that the patient does have, and negatives, or symptoms that the patient does not have from the review of systems. And finally, step 5 at the very end, you can include significant pre-hospital EMS events, so whether the patient was giving certain medications or interventions before they arrived at the emergency department. You can include PMD and relevant subspecialist names, and you can include any other pertinent information. We're going to continue with the same video. Identify associated symptoms and notable events.
Noted. Tom, do you notice any lightheadedness?
No lightheadedness.
Okay, how about any palpitations? Is your heart beating really fast?
No, it just
Any
hurts.
vomiting?
No vomiting.
Any sweating?
Yeah, some sweating.
Okay. Patient, to continue the HPI, patient notes some associated diaphoresis, however, notes no nausea, vomiting, lightheadedness, or palpitations. Okay, Tom, we're going to do.
So we've just now practiced taking down different elements. Now we're going to move into organizing your HPI elements. So different complaints should be described separately and in series. In the example that we just used, the patient had one chief complaint of chest pain, but there are often multiple chief complaints for one patient. For an HPI that includes chest pain, shortness of breath, and a racing heart, again, these complaints and their modifiers should be described separately and in series. So, in this example, elements of chest pain should be described together, then elements of shortness of breath should then be described together, and elements of a racing heart should then be described together. Your description should be analogous to the branching of a tree. The trunk comes first, then the large branches, then smaller for each of the larger. Right branching descriptions are more suited for English language processing, so it's important that your modifiers come after your chief complaints because it is easier for the reader and the recipient to understand what you're trying to communicate. To further organize your HPI elements, use simple sentences rather than compound sentences. Again, this just keeps it simple for the reader and the recipient to understand. You must contain all of the pertinent details, so make sure that you're being thorough in your note-taking, and less is usually more. So keep it simple, no need for fancy language in your HPI. The HPI is a subjective record from the patient, therefore you need to avoid objective findings and diagnoses in the HPI. This is really important, so you want to keep things subjective and you don't want to make any conclusions. So one example of objective versus subjective findings is syncope versus loss of consciousness. This is something that you'll see quite often because syncope is often characterized by a loss of consciousness, but that's a diagnosis in itself. In your HPI and subjective record, you should only include loss of consciousness.